aging thing is not true. If anybody tells you it's normal to get a lot less sleep as you get older, find a new doctor. Even if there's stress, depression, anxiety going on, you don't want to ignore the sleep.
I'm Dr. Shelby Harris, a clinical psychologist and board-certified specialist in behavioral sleep medicine, authored The Women's Guide to Overcoming Insomnia, and translates science into nightly peace for women in midlife.
You might be sleeping 8 hours a night, but if you feel like it's not restorative, that should be a big sign that there might be something going on with your sleep.
What makes sleep in midlife uniquely layered?
Biology is a big component. We see the hormonal changes. Then we also see more anxiety and more depression. And then the third piece that doesn't get talked enough about is
So how do you really bridge that gap?
people want a quick fix. Medication's not a problem, but it shouldn't be a first-line treatment. You have to think about the exit strategy.
Apnea is often overlooked in midlife women.
You don't have to snore to have sleep apnea. You can have pauses in your breathing, little chokes and gasps. The one caveat I always give is if there might be something else going on.
Expert care for menopause and sexual health, now just a click away. Virtual Care by Her MD offers longer visits, personalized treatment plans, and trusted providers, all from the comfort of home. Learn more at hermd.com. This episode was sponsored by Her MD.
All right. Dr. Shelby, a dear friend and colleague. Hey, girl. Hey, how are you?
So so great to be here. Thanks for having me on. I'm really happy to be here.
Oh, my God. I actually can say I slept well last night. You and I need to talk, and I need to see you as a patient. And I have been sending people your way, by the way, when I have tried all of my lotions, potions, and environmental changes. So we'll get into that about setting your room up like a spa. Yes, I have tried all the things, let me tell you. So you and I both see women struggling with hormonal changes and discovered that sleeplessness, what a nice word for nighttime torture, was really a hidden tipping point. And so what was your passion? Why was your why? Why sleep?
Well, sleep, I've always been interested in sleep since I was a little kid. I was a sleepwalker. So I was always like fascinated. I know. I was fascinated with like, why would I do these things in my sleep? I'd have no idea that it was happening. And it's hereditary too. So like, I was just interested in sleep. And then when I took a year between graduating from college and going to graduate school, I was put at the Brown Med School. I was put on a study looking at alcohol dependence. And they had me going to a rehab. So people who were in early rehab, we were actually treating their sleep problems. We were using trazodone at the time. Now they do it without the meds. But we found that when people were sleeping better early on, the risk of relapse reduced significantly because people were going back to alcohol because they weren't sleeping. And I was just like, why are we not talking about the importance of sleep? This is 25 years ago. Why are we not talking about it in other areas? And that's what kind of set it all off for me.
I don't ever remember actually learning about sleep in medical school or residency. I just remember chronically being sleep deprived and then seeing a study about. I remember driving home one day and falling asleep after being on call for like 48 hours. This is before the restrictions.
Yeah.
And then I walked into the kitchen because it was morning and my husband was asking me a sentence and I couldn't complete it. And he was like, you know what's really scary? He said, you were just driving a motor vehicle. I said, no, what's even scarier is that I was just operating on someone an hour and a half ago. And then I saw the data that came out that sleep deprivation is actually worse for you than driving under the influence, or you do worse driving a car.
It's the same as being drunk, legally drunk, essentially.
That's crazy. Yeah. And we were all doing it as medical residents. And operating. I was operating on people. I was delivering babies and doing cesareans in the middle of the night.
Yeah, no one was talking about it. When I started out in the field and was working at Montefiore, initially there were surgeons who would say to me, like, who were older, and they would say, how can we teach ourselves to live on less sleep? And it's like they can't fake wake, dude. Like, there's only so much you can do.
There's only, and at the time, they did have restrictions for pilots and other people that did, I don't want to say jobs that were riskier, right? That could put others in harm's way if you were not able to do your job at fullest capacity. So we're not going to say we're more important, but, where we could hurt someone by being impaired by lack of sleep. And so that always gets me. But I want to go back to the sleepwalker because, I'm a mommy and I did not know it was hereditary. So my youngest, we would joke we would find her in other rooms in the morning. So my husband and I always had to make sure the baby gates were up, that the doors were all locked, because it was a joke of, she's going to kill me for saying her name because now she's 16. Where's Maya? And where's Maya going to be in the morning? Because she would do that. And I remember taking her into the doctor once, like to the sleep clinic at Children's. And they basically, tried to ask her why. And she said she was scared and she would have nightmares. And then when she would get up from her dreams, so she actually remembered. So I don't know if that's technically a sleepwalker. She remembered moving. She didn't she remembered the intention. She didn't remember wandering around, but then she remembered moving to somewhere. So I'd find her with her dog or, her blanket or stuffed animal, but just somewhere else in the house. But then it just stopped. Is that what happens to sleepwalkers? They outgrow it?
It typically does. We always think about it as sleepwalking, sleep talking, night terrors, sleep terrors. We think about it like on an old school car with gears, like you're shifting gears between sleep stages. And it's like you're getting stuck between wake and deep sleep. And that's what happened. So you're kind of doing both things. I had no recollection of it until my dad thought there was a burglar and I was trying to walk out the back door and he screamed and woke me up. But I didn't know I was doing it. Yeah.
So is that also what they call hypnagogic hallucinations?
Totally different.
Or is that totally different? So when I wake up and I think there's a spider next to me and I start frantically going like this, what is that? What is that?
That's a hypnagogic. That's a hypnagogic hallucination.
Or hypnopompic. When you're waking up, waking up is hypnopompic. Hypnagogic. Those are hallucinations. Those are different from walking and talking. When I was opening the door, I was sleepwalking and my dad literally just was screaming and woke me up because he thought there was a burglar. So it's all right. It's all good. But safety. Yes. For anybody who does this, gates up. And if you start doing it or didn't outgrow it and you started as a teen and adult, get it evaluated for sure. It can be medications, can be other things. We always want to not ignore it.
No, for sure. And that's why we took my daughter, and they didn't seem too concerned because we were doing all the preventative measures. And then I think, I can't remember what age exactly she outgrew it.
Yeah, I was 12 when I outgrew it. So it happened.
She was a little bit younger, I think, or at least I stopped finding her in other areas of the house. So for sure. Okay. See how we're already off track?
All good. Yeah, everyone talks about sleep and they just mean insomnia. It's a huge field. It's like a whole specialty. And there's so many sleep disorders out there. So, and I love talking about all the strange things we do in our sleep. So it's all good.
I do too. I was always fascinated personally and also medically, about dreaming, about sleep, about lack of sleep and all the things. Because I've struggled actually way before perimenopause and menopause. I struggled as a teenager. And then obviously for me, it really got bad in residency because I had to train myself because I also had a baby at the time. So I had to train myself to be up to nurse or to address the needs of the baby. And also, if my pager went off, I had to. So it was almost like I trained myself to never allow myself to go into a deeper state of sleep because I was so worried about missing the baby crying at home. And so it's like I never recovered from that. I've always been, my husband jokes, the lightest sleeper. I can hear the whimper of a puppy in my sleep. And he is always shocked at how well I can hear when I'm sleeping.
It is a question I probably get asked at least once a week. People will say to me, I was a great sleeper until I had my kids. Then when I had my first kid or whichever kid, they weren't sleeping well. But then a few months later, they started sleeping well, but I continued to sleep poorly. Why is that? And it's that same reason. And then the other thing is with people who have pagers that have to go off or get calls and work on the call, that just makes it hard too. So you have the double whammy. Yeah.
I had the double whammy and I had it simultaneously going on at the same time. I had a baby, but I was like, well, if I'm not sleeping at work, why sleep at home? I mean, that who knows?
Out of the way.
As logic. Get it out of the way. Have them young, get it out of the way.
Yeah. You're trained in cognitive behavioral therapy, a gold standard that many doctors still don't offer, actually don't even know about.
Yeah.
In your mind, why should insomnia treatments be frontline for menopause-related distresses?
Well, I would argue that insomnia treatment should be frontline for any issues, right? So we often think about the old school way of thinking about it is insomnia is secondary to another issue, right? So you're having hormonal problems. Once we get the hormonal problems set, then your insomnia will be fine. Depression, anxiety, then your insomnia will be fine. what we actually, even pain, any other medical issues, what we find is that in a lot of the cases, if you're not addressing the insomnia specifically, it continues on for various reasons. So we need to treat it with its own weight and really think about it, because if you're not sleeping well, it impacts all the other things. So we think about perimenopause and menopause. What are some of the common symptoms that women have? Hot flashes, night sweats. They're having more anxiety, more stress. They're waking up at 3 a.m, like really, tense. And there's so many of those symptoms that are happening.
Depression,
They're
anxiety.
waking up to pee. Like, that's what they tell me. They're disrupted because of the GSM. Yes.
So common.
But if you're sleeping better, it helps with a lot of those other symptoms. It doesn't mean it's going to cure everything, but I always think of sleep as like the bedrock for all the other things that are happening. And if you're not coming in with like a good, solid foundation, it's going to make it harder to make movement on the other things.
Well, it's a vital sign too, but I joke with what I do with sexual health, because patients are like, I'm like, do you want anything for your low libido? And they're like, no, Dr. Gervais. And I'm like, why? They're like, because I would rather sleep. And I was like, I hear you. They're like, fix my sleep problem, and then we'll address the sexual health. But I'm like, that's so true. She's like, I see the bed and I want to go to sleep. I don't want to mess around because I'm only getting, 2 or 3 hours of quality sleep as it is. So I don't want to take time to be intimate or to have sex. Like, I'd rather be sleeping. And I'm like, that's the most honest answer. So then we prioritize, like you would recommend, and we take care of the sleep. But I want you to pause for a moment. And so we talked about some of the adverse things that can happen when you don't sleep, right? But can you talk about the benefits of sleep? Like, what happens when we sleep well? Like, what is our body doing while we're sleeping?
So there's different stages of sleep that are happening. So you have light sleep, like we're just stage 1 when you're falling asleep, that kind of like, am I awake or am I asleep? And then stage 2 is this, I always consider it like a middle level. And that's when you have a lot of, it's restorative for energy, but you have a lot of memory. We see certain things on a sleep study that happen, and you have a lot of memory formation then. Then you have deep sleep. That's stage 3. People are always like, I want deep sleep all night long. You actually don't have it all night long. You have about 20% of the night is that deep, deep sleep. That's when your body is repairing itself. So we think about if you exercise, if you've got an injury, if you're younger, growing, right? These are all the things that your body, your cells are literally repairing themselves and growing. So it's super important. That's when growth hormone comes out. And then REM sleep happens. And REM sleep is really important for memory, for mood. If you're not getting enough REM sleep, you can have a lot more mood instability. So we really think about a kind of a sprinkling of the different stages throughout the night to keep everything at that baseline, as I was talking about.
So your book, author, yay for you, shows that women experience insomnia across their lifespan, from puberty to menopause. What makes sleep in midlife uniquely layered? And how do you help women understand these shifting root causes? So you talked about this, hormones versus anxiety versus behavior, or does it all just kind of go together?
I always think about sleep in midlife as this perfect storm in 3 different ways. So like we just said, the hormones, biology is a big component of it, right? And I see women all the time in my practice in their mid to late 30s who are starting to have some of those changes happen, but people don't always put 2 and 2 together. So we see the hormonal changes. Then we also see more anxiety and more depression in women just in general. And then the third piece that doesn't get talked enough about is the societal kind of stressors that happen. So women are having kids a lot later in life now. So they're in the sandwich generation when they're starting to go through perimenopause and menopause. They have, I'm there, have the parents they're taking care of, the kids who are younger and becoming teenagers. There's that stress, and they're working more than ever. So inside the house, outside the house. So there's no demarcation between day and night. It's just like go, go, go. So that's that, like you put those 3 areas together and it's like, no wonder we have more insomnia than men a lot of the times.
And so you're a trailblazer in really leading this charge to start recognizing and using cognitive behavioral therapy as first-line treatment for women. What resistance have you seen in clinical care, and how do you help both women and providers kind of bridge that gap and be like, because when I mention it, they're like, Dr. Big, come on, can't you just give me a pill? Like, that's the first thing I hear. Can't you just give me a pill? And I'm like, well, that's not a long-term fix. Hear me out, because now you are menopausal and this is your forever stage. I mean, I know we use postmenopausal, but it doesn't mean you're not going to have symptoms. Exactly. So how do you really bridge that gap?
I love that question. There's a few things that I think are the big barriers right now. So one is the name of it. So I'm a psychologist, I'm a therapist by training, love therapy, but I think there's still that stigma for a lot of people. So when you call something cognitive behavior therapy, it's a little bit of like typical therapy, cognitive behavior therapy, but it's not. It's very behavioral and working on like training your brain so that you're not like really anxious about sleep. And it's short term. I see people generally 4 to 8 sessions. I don't even see them every other week. I see them online like every 2 weeks usually. It's short term. So I think that has to kind of get destigmatized a bit for people to think you're not going to long-term therapy for years. It's very effective. Like you were talking about the medications. People want a quick fix. CBTI sometimes take a number of weeks. They say you got to give it at least a month, 2 months to really see if it's going to stick and hold. The medication, the way I always talk about it is like medication's not a problem, but it shouldn't be a first-line treatment because you have to think about the exit strategy. A lot of these women are getting started on meds in their 30s and 40s, and they might not have any side effects from it right now, but put them when they're 60. Then we might have more cognitive issues, more risk of balance issues, falls. We need to think about that because it's rare that you just stop a pill and you start sleeping well again. So you need to have those techniques and those skills in place. And I think the other big problem is that there aren't enough trained providers in it. So people who really want to see someone who's a true specialist, there just aren't many of us. And that's a big problem in the field. That's why I wrote my book. That's why there's apps. But if you're more complicated, you're on meds, or you want that real tailoring, then you really want to see someone in person.
My mother actually ended up in the hospital from Benadryl withdrawal. So her doctors kept denying. So she definitely has, after she struggled with cardiovascular disease and having her quadruple bypass at 45, she just became very anxious because she went through she almost died, right, at a very young age and wasn't expecting it. And so she had trauma. Now I can recognize it was trauma and fear of almost going to sleep and thinking, and then she would have racing thoughts. And her doctors thought it was better than treating the underlying issue, or maybe they just didn't know or have the tools, or I don't want to blame them because I get it. I'm a doctor. I don't know everything. But they told her it was safe to take Benadryl every night for 2 years. And so I was on a trip with her and we were sitting at dinner and she goes, I don't feel well. And I go, oh my God, Mom, is it your heart? And she goes, I don't know. She got dizzy. She got hypotensive. She kind of fell to the ground. We had to call the squad. And lo and behold, cardiac rule out, thank God. But it ended up being Benadryl withdrawal. I mean, you would never think, right? Over-the-counter medication, we're not even talking Ambien or one of the prescriptions. We're talking over-the-counter. How many people, I know a lot of women who come to me and say, oh, I just take a Benadryl, and it's like, you can't do that long-term either.
No, and the reality too is that I was literally just having this conversation with a patient this morning who like went to the pharmacist, and the pharmacist was like, I would rather you take Benadryl than you take this Sonata you were prescribed. I was like, actually, reverse that. The Benadryl has way more data on cognitive problems and falls Sonata that you were prescribed. I would rather the prescription than the over-the-counter. Yeah, Benadryl, still people suggest it, and we really never use it in the sleep field.
Yeah, and I will tell you, after my mom's experience, I will never tell a woman, I might prescribe her, especially women will come to me and say, hey, I can't sleep at all when I'm traveling, particularly when their environment changes. I'm like, okay, I'll give you Ambien for your trip or short term, but long term, we have to figure out, once I've done the hormones and everything, then I send them your way. I say, you need to figure out what's going on to fix this. So sleep disordered breathing, apnea, is often overlooked in midlife women because they don't fit the typical stereotypes, right? Which is, you think of the kind of over ideal body weight gentleman, or the gentleman with the really, thick neck, or you just don't think of midlife women. So what signs should both women and clinicians be on the lookout for apnea?
Yeah, the questionnaire that's used a lot is called the stop bang questionnaire, and it really is not very effective for women. So if you're going to someone who's just using that as your questionnaire, like to screen you, it might be missing things.
So Shelby, that sounds more like my life in Stop Bang. I mean, that sounds more sexual health than it does sleep. I'm sorry. I had to go there, girl. I told you. I don't know. See the thing? It is funny. I was like, I haven't heard of it. Okay, tell me more. The thing is,
I look at, because I see women come to me with insomnia, and I'm like, I think you have sleep apnea too, or I think that's the main thing going on.
it presents less of the typical, for many women, less of the typical, like, excuse me for making this noise, like that kind of noise. I know it's really effective. It can be you don't have to snore to have sleep apnea.
You can have pauses in your breathing, little chokes and gasps. It's much more subtle, gets missed all the time. And then the other things I think about are like, how do you feel? Do you feel like your sleep is not restorative? Do you feel like you have broken sleep at night? Do you notice, like, women don't often say, like, I'm super sleepy, I'm falling, I'm taking naps, they're more like, I'm tired, I'm just dragging all the time. And you have insomnia, but if you have any of these other symptoms, you might have an apnea, like a pause in your breathing that's waking you up, and then you have insomnia on top of it. So we kind of need to treat both things. And the one caveat I always give is if you go and you're pretty convinced there might be something going on with the quality of sleep, and they give you a home sleep study. Home sleep studies are great. A lot of people don't even want to see a doctor or sleep doctor because, like, I don't want to sleep in the lab with all this stuff. The home sleep studies are generally pretty good, but they're screeners. So if we know that if we see on a home sleep study that you have apnea, then we know you have apnea. We're pretty good at it. We've caught it. And then they can go and treat it. But it misses apnea a good amount of times too. So then we might need to do an in-lab study. So if it comes back negative and your doctor's like, you're fine, don't worry about it, I might try to push a little bit more. There might be something else going on.
Yeah. So what do you say to the patient? Because this is what I say. So this is the second pushback I'll get after, can you just give me a pill?
Yeah.
Is Dr. Javaid, I'm telling you, I'm not sleeping well at home. And now you want me to go sleep in a lab or sleep in a foreign environment? So what do you say to that? And can I give them an Ambien or does that throw off your results?
Be honest.
We can
talk about that. So that's where a home sleep study is a good place to start.
Most insurance is always going to start with a home sleep study. They can, and I've done them myself, it can either be like a nasal cannula, and then you have an under band and a pulse ox. They're simple. And then there are some like watch pads that are literally a watch with a pulse ox, and you don't even have to like return it. You just throw it out.
Nice.
They're crazy. And so like if it shows something, then you don't have to sleep in a lab. You're fine. So it's not a worry. The Ambien is always something to discuss with the prescribing doctor, or any sort of sedating medication. Only reason, like sometimes we use it in the lab. I'll have patients sleep with it if it's the only way they're going to get like 2 hours of sleep at night. You don't need a perfect full night either. We just want to see your breathing. But sometimes the medications can worsen. This is the other thing. They can worsen underlying apnea. So people who might have apnea, but you're like, I just want to, or they're like, I just want a pill. If you think there's apnea, you might actually make their apnea worse, even though they might now have more breathing issues and they might wake up with more problems long term.
Yeah, and apnea can lead to problems, right? Correct me if I'm wrong, with heart disease and not getting enough oxygen to your brain, a whole host of this.
So unique cardiovascular issues. We see a lot of, we're talking about midlife, right? So there's a lot of issues with people with apnea that struggle to lose weight, right? So because you're not sleeping, you're literally not sleeping, and it can create metabolic syndrome issues. So we really want to treat that apnea if it's really, and it doesn't, you have to have a mask on your face too. People also assume that that's the treatment. That's not the only treatment. So we have lots of treatments for different severities and types.
And I had that stereotype in my head too of the, over ideal body weight gentleman or someone who's got, a thicker neck. It wasn't until really I went for my ACLS and started doing surgery and was talking to the anesthesiologist who would do a thorough examination, right, of soft palate, mouth, nose, everything, and give people an anesthesia score to see whether or not they were good candidates to do in-office surgery, because I did a ton of in-office procedures as a gynecologist. And I was shocked sometimes at my tiny patients, the ones that were super fit, that the anesthesiologist was like, no, not a candidate, due to their anatomy. And it's not their neck, it's like in their mouth. And so I think for women, I want that messaging to be, please don't self-blame or loathe if you're snoring. Because I hear women say, well, I'm snoring now because I'm fat, or I'm snoring now because I've gained weight. And it's like, well, you don't know what's going on. You don't know your anatomy. And so I agree with you that women really need to understand, what's going on, and are they apneic or are they just snoring?
Exactly. And the other thing to think about too is that when you start to have hormonal changes, there is a loosening of the airway. So apnea is essentially when you fall asleep, for all the listeners, when you fall asleep, things loosen, right? And that's just what happens. Your muscles loosen. And when you have apnea, they essentially loosen so much that you have a full or a partial closure. So and you wake up. It doesn't have to be that pronounced. But if you're taking a sedating medication, this is going to happen more. And we want women to realize that it might not be because of weight. It just might be, like you said, the anatomy. And then once you hit midlife, things just your muscles loosen to begin with. So that can also loosen things. It doesn't have to mean you gained weight or who knows. Many different things that we have to look at. But yeah, thin, fit women. I have women in their early 20s that I diagnose with apnea all the time. I send them off and we find they have it. And they're shocked.
They're shocked. And so I don't want them to feel alone. And I'm so glad that you said that you've seen it as young as their 20s and people that you wouldn't think fit in that stereotype, at least that, I thought of even as a doctor until I really, really learned. So many women become hyper vigilant after years of interrupted sleep. You've coined the term sleep threat conditioning.
Yeah.
How do you help women retrain that brain away from fear and moving more towards that rest and relaxation?
Yeah, I think so. The sleep threats that we talk about in sleep medicine, it's really like when women aren't sleeping well. And this is the thing that I hear the most often is, I get in bed and my husband or my bed partner is not snoring that much, but they just breathe and I focus on their breathing. Or sometimes let's be real, if they're snoring a good amount, we need to get that evaluator, have them sleep apart. Sometimes it's just hard to sleep through those things, but they're listening out. I've had patients listen out for they'll hear their heartbeat, or they'll listen for the air conditioning and really try to fix the air conditioning system because it's something that could get in the way of their sleep. So it's really about what is a realistic thing that's happening routinely that you just physically can't sleep through versus are you scanning the environment for things that are getting in the way of you being able to sleep? And so we might do the typical earplugs, all that sort of stuff, but are you really blowing it out of proportion? So then I might actually do exposure exercise. This is anxiety, right? So if you fear the air conditioning, I might have you sit and just listen to the air conditioning all night long and listen to it and say to yourself, essentially, I'm not going to sleep tonight. I'm not going to sleep tonight. So you get over the kind of anxiety that happens and it's like going over a bridge. It's the same sort of thing. So we might do that. And then the other thing too is that sometimes people are getting in bed too early or they're sleeping in or they take a nap. So they're not as sleepy as they normally would be when they get in bed. So if I limit their time in bed a bit, believe it or not, they're going to fall asleep faster. And when they have an awakening, they're so sleepy because they're not allowed a full 8 hours in bed. They actually fall back asleep faster because they're too sleepy to scan for the threats.
I love that advice. I hear women say to me, though, that they dread the nighttime, or as soon as it starts to get dark in the summer, they can actually feel their anxiety because they already are preparing themselves for a night of not sleeping or tossing and turning all night. So I've heard it. I just didn't hear that phrase until I read it from you. So very interesting. For longevity, we know this, and for resilience, sleep cycles matter. What's one overlooked marker or metric that every woman in midlife should be tracking? And how does a provider use that piece of data to personalize care?
So I don't think everyone needs all the fancy trackers that are out there, like the rings, the watches, because if you have insomnia, it actually can worsen insomnia in some people because they become hyper-focused on it. But I think just getting old school and just writing down your sleep on it. I have an example in my book. You can get them online easily. Just writing down your sleep during the night and just what time did I get in bed? What time I wake up? Caffeine use, all that stuff. And then just looking at how much sleep you're getting on average. And the thing that I think gets missed a lot is the quality of your sleep. So you might be sleeping. People focus do you sleep 8 hours a night? Fine. But if you feel like it's not restorative, if you're tired, if you feel 2-3 hours after waking up, you could go back and take a nap or you need to rest, that should be a big sign that there might be something going on with your sleep, even if you think you're asleep the whole night. So it's really about how you're feeling. Usually you're at your peak energy level. If you wake up, let's say at 7, by 10:30 in the morning, you should have much more energy. You might not right when you first get up. If you're still dragging by that time, there's probably something going on that you need to look into.
So this is a question that I didn't have ahead for you, but I'm just curious because I get so many questions about this. Just over the counter, not necessarily trackers, but recommendations, whether it is thermoregulatory, pajamas, sheets, what else am I thinking about? Should people sleep blindfolded. I was for a while sleeping with noise blockers because I do sleep next to a snorer. And then one of my girlfriends made a comment to me, well, if he has an event, then you won't hear him. And I was like, well, forget that. Now I like, forget those. So I got rid of those noise canceling, like Bose makes them. I was like, okay, I can't do that anymore because God forbid if something happens, I want to obviously not be that, impaired. But what are some of the things that actually do work? Because, everyone's trying to enter this menopause market, right? And so there's so many sworn by solutions. But what are some of the things that actually you've seen work and can help with an overall sleep program?
Yeah, I think we're talking about tailoring, right? So if you're feeling something's happening with the quality of your sleep, or you're waking up a lot at night, but you're not up for very long, think about the temperature, right? That's a huge one. And I really do think these are very cost prohibitive for a lot of people. But and I don't get paid by them at all, but like 8 Sleep, Ooler, there are these, you can get the mattress itself, but you can also get like mattress pads that go on one side of the bed. And that actually can it's like basically got thin jets of water in them. And so you put the base under your bed, and you don't even know there's water in it or jets or anything. And it can make your temperature go down in the middle of the night. So if you're someone who wakes up warm, you're having hot flashes, night sweats, that actually I do find helps some people in the middle of the night. Mom, go ahead.
Shelby, I think 8 Sleep needs to pay both of us because I will tell you it was a game changer for me. And I feel bad sometimes recommending it because it is more expensive it is expensive. It is. But I remember sitting in a green room and there was a bunch of doctors in the back and we were all going through perimenopause and menopause. And we were talking about what are we doing to sleep because we're traveling, we're talking, we're speaking, living your life. And 100% of us had 8 Sleep.
Yeah.
And said it was a game changer because for me, it probably auto-regulates the temperature over 20 times a night. I'm no longer waking up. I mean, I'm also on hormone therapy, but I'm no longer waking up in the middle of the night with that hot flash.
And the reality is hormone therapy can really help a lot of people, as you obviously know, but it doesn't help everyone, right? So there's a lot of residual sleep problems for various reasons. So CBT is really also something weirdly that can help with the hot flashes in the middle of the night without even doing any temperature things. But I do think people keep their rooms too warm, or they keep getting at the temperature they want, or they have a bed partner that just has a different internal thermostat. And I really think that's a great product. And then also sweat wicking pajamas. I mean, there's not one brand. There's no one size fits all. That's kind of what the Oslo earbuds, which used to be Bose, those are really popular. If you like sleeping with earbuds, then go ahead. If you're not able to block all the light in your room, then there's eye masks. It's really about finding what works for you. And then also with the temperature in the room, there are cooling bedding products. So you don't have to go 8 Sleep, but you could try Slumber Club. There's other companies out there that make cooling pillows, cooling mattress pads, cooling sheets. So you could start with that and then work your way up the cost ladder.
So the other question I get a ton, and I'm actually curious for myself too, is that we tell people to stay off their phones, to not watch TV, especially if they're having problems, right? And to create this sleep environment. What about apps? How do you feel about apps? Because I used Calm for a while, but then patients will say to me, you're telling me to stay off my phone, Dr. Jabade, or put it in a different room, and then you're telling me to use an app. They're like, so which one is it? Or is it a different answer for everyone?
No, what I actually recommend, so the blue light thing from the screens is actually quite hotly debated in the field of sleep medicine.
Okay, interesting.
The data, I mean, it does impact somewhat, but it might not be the thing that's causing the insomnia of hours to fall asleep for many people. The bigger issue, many of us argue, is it's more of what are you getting sucked into? Most people are doom scrolling on their phone, and then they're getting the text, and you can blame it on the blue light. You can put on the blockers all you want, but if you're still on doom scrolling on things, good luck with that. So it's really about the phone. And I think the talking about, or the content on the phone, but then also talking about the meditation and stuff that people are doing. What we actually think about in sleep medicine is I had people do the meditation during the day. I'm having them practice strengthening their ability to let go of things during the day, because at night, when you wake up at 3 a.m, I don't want you taking your phone out and getting sucked into it. I want you stronger from your daytime practice. So ideally, that's when I want people off their phone, is just before bed and not relying on the apps to fall asleep to. They can do their own meditation, but try to keep it away, because it's usually most people can't trust themselves with it.
So I can doom scroll during the day? Just joking.
All you want.
All right, rapid fire, girl. You ready? Okay. a hormone or a hormone imbalance that may keep women awake that doctors don't test for?
Okay. You're much more of a specialist than I am, believe it or not, and the hormone stuff. We just are still learning in sleep medicine more about the hormone relationship with hormones. Believe me, like when I wrote my book in 2015, 2016, there was so little on sleep in women.
Oh, there still is. I mean, we're learning. Yes. Okay.
I don't want to say something they're not. I think there's a lot that's probably not being addressed. I'll leave it at that.
Best sleep tip for women balancing night sweats and anxiety.
Oh, I would make sure if you're having anxiety, you're waking up sweaty, make sure it's not also a nocturnal panic attack, because those happen a lot and people don't realize it. But if you're waking up and you're sweaty, I mean, first of all, go with the sleep sweat wicking pajamas, the cool bedding. And then what is it you're waking anxious about? So if you're anxious about certain things that always seem to be on your mind in the middle of the night, get it out of your brain before bed. So, and like we talk about worry time, really worrying the heck out of things for 20 minutes in the early evening, writing it all down, getting it out of your head. And then after worry time's over, you say, not now, during worry time tomorrow. And it sounds very simplistic, but it's like you're allowing yourself to worry. And then those other 23 and a half hours, you say, nope, I'm not going to worry about it now, but I'm going to worry the heck out of it for those 20 minutes during my assigned worry time. And that actually can help soften things.
And it doesn't hit people at night because they're not addressing maybe work or kids or parents or everything else because they have time to pay attention to their worry? Is that why it hits people at night?
Very common reason. People will often be so sleepy at bedtime, they pass out, and then they'll say, why do I always wake up at 2 or 3 in the morning? Usually they've had a natural awakening. That always happens. We have natural awakenings, but you've slept a few hours. So now your brain can be a little bit more alert. So you need to get things out of your brain before bed.
Feelings on melatonin.
Melatonin is wonderful in low doses for certain things, for shift work, for travel. It's great for jet lag, but it's not the most effective thing for just standard insomnia. People take way too much of it.
And not meant for long term, correct?
We mostly use it to shift people's sleep-wake schedules, night owls to become early birds, things like that. And we use it for a few weeks to months just to get you set.
Is there a singular wish or piece of advice that you recommended each clinic offered to menopausal patients regarding sleep?
Single wish or advice? That's a great question. It would just be like, are you content with your sleep? Are you content with it? Do you feel well rested? Do you feel like there's any problems? And if there isn't, to give an automatic referral to a sleep specialist.
I love that so much because I think that's the easiest place to start is for providers to even ask the question. You won't know that there's a problem or an issue with your patient if you don't take the time to ask that singular question. Okay, gonna get personal. How do you unwind after your own sleepless night?
If I had a rough night, which I do, I'm human, right? The first thing I do is so we're talking about in the morning, right? I lots of cold water. And then I try to get in a workout. I work out in the morning, but I won't necessarily do a really hard workout. I'll walk really briskly. I'll do something that's kind of like a lower intensity exercise, and I get a lot of light. And that is what helps me during the day. And I accept that I'm going to be tired, but I'm probably going to sleep better the next night.
I love that because you're doing what so few women do, which is we extend grace to so many people, but sometimes we hold back on that grace for ourselves. And that's what I remind patients too who are so hard on themselves. I'm like, that same grace you're extending to other people, extend it to yourself.
Exactly.
So women often hear though, oh, it's just stress. When they do complain to their doctor and they finally are able to articulate or get the time, or they say it's aging, before they're told it's sleep, what's the truth every provider needs to say, train, or treat for?
So I think I tend to assume sleep first and foremost before I think about the other things. So first of all, the aging thing is totally not true, right? So we get a little less sleep as we get older, but not usually hours less. And it's a little bit more broken because of pain and having to urinate more at night, things like that. But if anybody tells you, oh, it's totally normal to get a lot less sleep as you get older, find a new doctor first and foremost. If that doctor's not listening to you, and you're like, but my sleep is not feeling right, get a different doctor. Because like I said at the beginning, we think of sleep as a separate, it's like related but separate to, even if there's stress, depression, anxiety going on, you don't want to ignore the sleep. If you help someone sleep better, just in spite of all the other things going on, you're actually going to help their outcomes for depression and anxiety with a shorter sleep treatment. So don't ignore it. If a doctor's just telling you, oh, this is normal, or let's work on the other things first, try to find someone who's listening to you. You're the expert on you.
I love that. I say that to patients all the time. Nobody knows your body better than you do. No one does.
So true.
Okay, so it's 2035, which is actually not that far away. Insomnia is finally treated as seriously as cardiac risk. Menopause care includes sleep diagnostics. How did we get there? What did it take to change both clinically and culturally?
I think we are slowly getting there. The younger generations are actually better about it. Is that idea of like, I'll sleep when I'm dead. Like I work in the city that never sleeps. That culture is slowly changing, I think. So we're getting there. And there are companies that are now really trying to value nap rooms, relaxation rooms, really having limits. I think that's actually, we're going in the right direction. I think for clinicians, I think we need better screeners, and just people, like primary care is often, and GYN, like they're the first line, providers a lot of times. So like having a good screener of your sleep issues and just asking, how are you sleeping? A lot of people are too busy to even ask that. I think we need to get there. When it comes to behavioral treatments, I think we need to know where to refer. A lot of providers have no idea where to find someone who does CBTI, for example. We have great societies. They just don't know. So I think more education and just trying to not ignore the question, or not ignore asking about sleep, because people they wait for the person to bring it up because they're in so much distress, and that's not going to work.
No, that's not going to work. So actionable takeaways then are to track your sleep pattern, not just interruptions, advocate for next level care. Don't be afraid to ask your provider, do you screen for sleep issues? Do you diagnose them? Do you refer? Or are you just writing this off? And then try CBTI protocols before relying on sleep aids. Would you say that, or would you say in conjunction?
Yeah, I would say try first. A lot of times people are prescribed meds and then come to me because they want to get off of them, or that it's not working great. We like to try CBTI ideally first, though.
I cannot thank you enough for your time today. I love catching up with you and all the things. So can you tell the listeners where they can keep up with you, what you're up to, and how to learn more about sleep?
So you could look, if you want to just learn about me and learn about sleep, go to my Instagram at sleep.shelby. I'm pretty active on there, and I do a lot of education posts, but I also do like a weekly AMA. So people ask me not personal questions, more general questions. And that's a great place to really catch up with me. You can also go to my website, drshelbyharris.com. And then I have my book, The Women's Guide to Overcoming Insomnia. And I have the Essential Guide to Children's Sleep that just came out about 2 months ago, too. So lots of ways to learn about me and my treatments.
When midlife women can't sleep, every part of life starts to crack: health, memory, mood. Dr. Shelby Harris reconnects what's been broken. Retune your rest. Share this with anyone lying awake wondering if it's them or their body. It's preventable. Thank you so much for joining us today and for continuing to be a strong voice in the field and disrupting healthcare for women everywhere.
Back at you. You are. Thank you.